This next session, I think, is going to be really exciting. We get to hear from 4 entrepreneurs who are really at the forefront of using technology to expand access to healthcare and reduce the burden of diseases that should be preventable. These are people with enormous talent, great ideas, and a commitment to bringing those ideas to more people to improve more lives. But we're going to talk about what happens after you get the idea. Where do you go from there? What are the opportunities and barriers to implementing innovative approaches at a scale that can truly unleash their potential? So I'm going to bring these entrepreneurs out, and we'll get to hear from them directly. First, Dr. Aparna Hegde, who's the founder and managing trustee of ARMMMAN. Dr. Barry Finette is the co-founder and CEO of THINKMD and a professor of pediatrics at the University of Vermont College of Medicine. Barry? Dr. Rajesh Dash is the co-founder of HealthPals, an associate professor and preventive cardiologist at Stanford Medical School. And Sylvana Sinha is the managing director and CEO of Praava Health. Thank you all for being here.
Yes.
Yes. So just to begin, to get us all sort of on the same page, to understand who we're hearing from and who we're talking to, I thought it would be good if we could just sort of go down the line and get a 30-second, and I'm going to hold, the clock is going to hold you to that, a 30-second description of what you're working on. What's the idea? What are you trying to put out there into the world? And let's just go one by one.
Yes, so ARMMMAN leverages technology to create scalable solutions which are cost-effective to both increase access to healthcare information to women during pregnancy and infancy, so they demand care. And on the other hand, we use mHealth technology to create solutions where we increase access to healthcare delivery by improving training of healthcare workers through the country. And our programs are in 16 states in India. We reached across to 16 million women and children through our mHealth programs, the largest mHealth programs in the world, Kilkari and Mobile Mitra. And on the other hand, our mobile academy programs is actually training right now 150,000 health workers and will spread through the country in the next 4 years.
Perfect. Thank you. Barry, go ahead.
Yeah, so ThinkMD is a company it's a startup company coming out of Burlington, Vermont. The goal of it is to look at developing digital mobile health technology that transforms how a physician thinks and how a physician does a clinical evaluation and place it on a very simple to use digital platform that allows anybody to do a clinical risk assessment, integrated clinical risk assessment. Our technology was released just under 2 years ago. It's currently in 10 countries in Africa, South Asia, and Southeast Asia.
Great. Raj.
So HealthPals is a precision population health AI platform that's a layer of clinical intelligence over an EHR system that maps patient data into codified guidelines and best practices and produces automated checklists of what to do for what patient and what time, and provides that information back to health systems, providers, and even patients. And we're looking to reduce the burden of NCDs globally, especially in the underserved communities.
Sylvana?
I'm the founder of Praava Health, which is raising the bar for the delivery of healthcare in Bangladesh with its fastest growing consumer brand. So we're building a network of integrated family health centers featuring international standard doctors, diagnostics, and technology.
These are people who know how to talk about what they're working on, I think. That's pretty impressive. Raj, let's start with you. And I want to start with you because you have a great origin story. You found your co-founder on a matchmaking website. I mean, we're talking about digital technology for health here. I mean, this is great. Right from the beginning, it's built in.
Yeah.
And that's been, a colleague described that to me as sort of Tinder for people who want to found companies. That's probably not exactly what your experience was like. But so there's where you began. I understand you actually have an exciting announcement to share with us today. Why don't you tell us what that announcement is, and then maybe you could sort of trace the path from where you started to where you are today.
Yeah, so thank you, Michael. So very exciting announcement for us today. Just 2 days ago, we signed an agreement with the government of Telangana in India to deploy our platform across 350 of their Basti, Davarkana clinics, the slum clinics that are helping so many underprivileged people in those communities with our platform to help reduce NCD burden, gestational diabetes, and tuberculosis. And that is phase one of what will be a statewide rollout. And the magnitude of that deal is probably over $100 million over the next 5 years to deploy that program. So that's very exciting.
Congratulations.
Thanks.
So matchmaking site to deal with the government. How do we get there? What was the key moment that that pushed you
So
towards?
I'm a preventive cardiologist. I have no software coding background whatsoever. I thought Python was a snake, and it's not. And I needed a technical co-founder to build what I had envisioned as a preventive cardiologist at Stanford. I run a clinic that reduces heart disease in South Asians. I wanted to scale that platform. So foundersdating.com was the website, and I swiped right. You know, I think that we need sometimes technology to help us find matches, and actually this has worked out quite well. From founding the company, we went through this pretty rough road for the first couple years where we thought our solution was to show doctors at the point of care what they should do for a patient sitting in front of them. And they loved it, but they didn't have the budget or the vision to pay for that, and the business model wasn't there. And so we said, well, what about a health system? If we produced checklists for every individual patient and scaled that up to a population level for an entire health system, would that be useful? And in fact, it really is useful. And in the US, unfortunately, there's so many misaligned incentives in healthcare, it was actually hard to sort of find exactly where that first appetite might be. But internationally, single-payer health systems, state-funded health schemes like we're seeing in Telangana, they really are incentivized to reduce the cost of care and get better outcomes by focusing on prevention. Similar to how the vaccine programs have really made a dent in infectious disease mortality, they're dealing with a massive burden of non-communicable diseases, cardiovascular, metabolic disease in India and South Asia, but also in the Pacific Rim as well. And we think we can make a major impact by leveraging not only our technology, but de-risking it for governments with impact investment. And that's actually how this platform can be scaled, is with outside groups, private equity, foundations, even pension funds, putting up upfront capital to actually deploy these technologies for the health system at no cost, and really allowing our preventive solutions to take effect and reap the savings 3 to 5 years down the road.
Great, thank you, Raj. Aparna, I want to hear about your scaling journey, as it were. You're tackling an enormous challenge in maternal and infant health in India. You're also operating in a context where there are tons of pilot projects that sort of fail to reach scale. A lot of what Catherine was talking about this morning. What do you see separates initiatives that reach scale from those that just never get past that pilot phase? And how have you worked to position yourself to stand out from the pack?
Yeah. So the idea for ARMMAN and the programs we do came while I was doing residency in India, and I saw very closely how lack of access to preventive care information and healthcare access led to loss of lives that are completely preventable, of mothers and children. And very early on realized that if you want to impact India's numbers, India has some of the largest maternal child mortality rates in the world, you have to design for scale for day one. If you create resource-intensive pilots, they are very, the impact is seen, but then when it comes to scale up, you just can't create a parallel network, right? Government of India has a very massive public health infrastructure through the country. So it had to be designed for scale from day one, and in such a manner that when you scale up, there's no dilution of impact. So you have discrete programs that are proven, but the unit of the program remains the same, whether it's the first woman or the 20th million woman, right? So that's very clear from day one. Secondly, you can't create a parallel network. You have to leverage what already exists. So our programs leverage the existing government health workers and the community partners, NGOs. It is a very robust community NGO, network in the country, leverage that to create solutions. And also create a tech plus touch model. Technology, so when I saw very closely how lack of access to preventive care information led to loss of lives. Women would come to the antenatal clinic once, 200 patients waiting outside, waiting for 4 hours in the line to get just 1 minute with me, and they would never come back. And then they come back dying, and I have seen personally where I've seen a dying patient open the papers, and it's my handwriting, seen her in 3rd month, and she's never come back, and she's come back dying. And I realized, and suddenly mobile phone came to India, right? And suddenly realized that why not use mobile phone, because within 2 years, everybody had a mobile phone. Literally every family has a mobile phone. So why not use a mobile phone to send information across to women in the chosen time slot of language preference, time and targeted. right? But realize that though technology is great, you can use a mobile phone, you have to couple that with touch model. So you have to have, so we enroll women in the hospitals where it's integrated in the system of the hospital. So the woman thinks the hospital doing it for her. Then we enroll women in the slums because women come to the hospitals too late. So we leverage and incentivize the health workers, existing ones, to enroll women. And we also have a call center. So there's a touch piece also. The program is introduced to her by a health worker, but it still remains resource light because the health worker is not then needed to go weekly or monthly. The technology takes over. But if she has any query, because we have a voice call service, we have 3 tries for every message, 2 voice calls every week, pregnancy and infancy, missed call system if she missed any message. But again, if she's got any query, there's a call center she can call her, right? So it's very cost effective though, right? So, and now Kilkari, that's our program with Government of India, which took off after we did our flagship program, Mitra, very well, it's gone across 16 million women. So for us, cost per woman is 24 cents. Right? So applying these principles, we'll be able to scale across. And now we're going to add 4 more states every year till we go on to the rest of the country. Similarly with the health workers, right? There's an ASHA worker in every village. And the ASHA worker, who's a community health worker in every village, and she undergoes a 20-day training program when she kind of enters. But after that, there's no refresher training. So technology, mHealth, becomes a very good tool to be able to kind of, teach her, train her further. So we have this mobile academy program, again with the Government of India in 13 states in the country, where she's got 11 chapters. She can call in, 4 sections to each chapters, a quiz at the end of each section, and a bookmarking system. She calls in when she has time, and she can log off and log back again next time when she has time. And it gives her a certificate. So there's a very good tool to train the ASHA workers, and refresh her. And when you have a new, say for example, vaccine coming to India, that can be a tool of letting her know. So technology allows you to do that and scale up. And that's why we followed these principles at the very inception, and hence we've scaled across. So both Kilkari and Mobile Academy happen to be the 2 largest such health programs in the world.
Great.
Because we follow these principles.
Great. So we've heard about partnerships with community health workers,
And
with government, with impact investors. Barry, you've partnered with the global health community, with aid organizations, as you've worked to bring ThinkMD to scale. Can you share a little bit of your experience working with that sort of particular community with its own ways of functioning, and what you've found to be kind of the opportunity in that, but also some of the barriers? I mean, this is the global health and development community. I don't think I would be going out on a limb and saying that it tends to operate sort of according to its own rules with a lot of procedures in place that take a long time. How does that work together with something that needs to move quickly, like innovation?
Thanks, Mario. So that's a trick question. So think about a story. I mean, our personal story is that, think about, I'm an academic pediatrician. My background's emergency and critical care from northern Vermont, thinking that they have an idea how to transform and build a digital health platform, going into this global health community, where I work in an area where the venture capital or resources to build that technology is virtually zero. I don't come from Boston. I don't come from Silicon Valley. It's similar to startups coming from low and middle income countries. And trying to work their way into this environment is not without a number of challenges. The resistance to look at new technology, how it actually may be of value, the recalcitrance of organizations to come into that world and take a look at technology, or the barriers associated with it. So, our idea was to be tenacious and do the best we could. So we developed this technology. Clearly, if you want to make something prove it's of value, then you try to test it and validate it. We spent 2.5 years with very limited resources, working in 5 different countries with 7 different aid agencies and Ministry of Health, validating our technology, putting it in the hands of frontline healthcare workers, demonstrating that with minimal training, that they can do clinical exams that correlate with clinicians' exams between 85 and over 95% with each evaluation, and that was published. And even after that, there is enormous recalcitrance to look at these things. So what you have to do is build partnerships. You have to do a lot of networking. You have to have a lot of discussions with people, and you have to do the best to find people who don't have a fear of failure within all these organizations. It's a huge barrier for us because the internal fear of failure of the organizations we deal with is a major barrier. So we look for those early adopters who are willing to look at us and to maybe provide us a way forward.
Did you find anyone here today without a fear of failure? You don't have to answer that question. But seriously, I mean, was there one partnership that did provide that opportunity that sort of the rest of the system wasn't quite latching onto?
Well, it's not necessarily an organization. It really comes to personal people to an extent. So, for example, we had some early relationships with early adopters in Save the Children and in UNICEF, the two largest pediatric and childhood international agencies in the world. We also have key relationships in small program in Zambia with a school-based program where they're training their school teachers to become health workers. Both those have proved enormously valuable. We've developed enormous impact data with that. We've demonstrated its ability to scale with quality, and scale with financial sustainability, and they're both of value. So you have to basically not be very picky on who you want to work with at the same time.
Great. Sylvana, I want to turn to you. It's not as simple as just coming up with the idea and then unleashing it onto the world. There are a number of different decisions that you have to make along the way, and one of them is what type of enterprise you're building. Is it a for-profit enterprise or a non-profit enterprise? How did you go about making that decision, and how has that affected the way that you've been able to roll out this vision?
Thank you for that question. I actually was always very clear that I wanted to build Praava as a for-profit entity, because I strongly feel that the only truly sustainable form of economic development is private sector development. And there's an important role for philanthropy and charity, but in order for an economy like Bangladesh to lift itself up, there have to be entrepreneurs and sustainable businesses that are built. That's how the United States came to where it is today. That's how most of the global economy has been built up. And it has presented challenges because I think that funders are more accustomed to thinking about countries like Bangladesh as the recipients of philanthropy and charitable funds. And I think it's been a wonderful part of Bangladesh's journey. You have foundations like Gates and Rockefeller and USAID and World Bank and ADB and others that have done incredible things to help Bangladesh come to this moment in its economic development where, on social development indicators, it's doing better than any other country in the region. Life expectancy is 74 years, which is more than parts of San Francisco. And so this is an incredible moment, but now that we're here, I think it's time for us to invest in building sustainable solutions. And so that's why I came to the table with this solution. And in particular, I wanted to serve the middle class, which I believe is a really underserved segment of the population, and that has disposable income and is willing to spend on quality healthcare. And they're traveling in the hundreds of thousands every year, often selling land to travel to India and other countries. And I think they deserve solutions in their own country.
Great. I'm curious if others of you have responses to that same question. Just thinking about sort of going from idea to sort of structured enterprise, what were some of the really critical decisions that you made in that process? Whether it was, whether to be a are you all for-profit?
No, we are non-profit.
Non-profit, okay. So maybe, could you respond a little bit to that and why you came down on the other side of the equation with your model?
For non-profit?
Yeah.
For me, I saw day in and day out underprivileged women and children losing their lives for something that should be a human right. I think health and education should be everybody's right. A world that cannot take care of its women and children really is not a world that I want to be living in. And having seen so many deaths over and over and again, I didn't want, I see that in my own practice as a urogynecologist. I have my practice as a I can't offer less care because somebody cannot afford the kind of care that she actually deserves, right? So, and what I realized that when you create scalable solutions, the whole point is that when you design for scale, it's really cost effective, because if you're going to cost 24 cents to do a Kilkari program, I'm sending her information for 2 years of her life, it's cost effective, right? Because government spends far more money on the women's healthcare with less results. So if you can really create a very, a program that works, has impact, has proven impact, and is scaled up using technology, you can keep costs low. And in that sense, it's sustainable, right? Yes, and also a world where you and I can go online and get any information we get for free, but I will give the same information to a woman for a fee. Didn't work well with me. I thought that both access to healthcare information, all women should have access to healthcare information about how they take care of themselves and the children, and the access and training of health workers. These are volunteer health workers. If they should have access to training that can actually, so
Right.
that's why we have nonprofit.
So part of it sounds like, is clearly understanding who your market
Audience
is, or who
yes.
your clients are in this case. Raj, when you think about sort of this picture, first of all, who is your core client for the technology that you're putting out there?
So it's really the payer. I mean, basically, if you think about it, we're providing insights for health providers and health networks, certainly, but ultimately the person who is, obviously the patients are benefiting, the providers are benefiting, and that's our core mission, but the person we have to actually sell to in terms of convincing that this is a worthwhile endeavor are the people who are footing the bill for the healthcare. And that's really where the challenge comes in, is you need to make that case very clear to them, and it takes a lot of detailed line item budgets for what they spend on their healthcare for their population. But ultimately, they're at risk, and any at-risk health system would benefit, we think, from this type of a solution or other solutions like it that can help their population live healthier lives. The interface with our platform, though, is with the health system, and so we have a lot of moving parts. It's not an easy process. And I guess, hard things are hard for a reason sometimes, because these are tough challenges, but I think you need to make this era of technology available to those populations, and this is one pathway to doing it.
Barry, I want to come back to the comment that you made earlier. I wonder if is there one thing that you think the global health community could do to become friendlier to startup technology, to become better at adopting things that you can prove that they work, but to work those into the system?
Oh my goodness. I think if I had that answer, then a lot of my problems would be already addressed. I don't have an answer for that. I mean, it is a very complex, multifaceted, challenge in a sense. I think that maybe I'll come back to this fear of failure coming back. It's an enormous problem that I think fails. I mean, I started as a research scientist and a physician. If you want to fail at your career, constantly become a research scientist and a physician. Okay, every one of your patients are eventually going to die, unfortunately, but you really want to prevent that from happening. Obviously, and in research, you can't be successful in research unless you constantly fail to find out answers to things. And I would just have to say that I think there are enormous potential in people all through the world, and technology in the world, and people with great ideas. You need to take risk on them and to look at that. And this is not something negative to, again, let's say the Boston area, the Silicon Valley area, which there's a lot of growth and amazing technology. There's other places in the world besides that where new ideas come from. And I think there's an enormous missed opportunity there.
I think if I could just piggyback on that a little bit, and it relates to the work that you do as well, Raj. There's huge opportunities in our markets because we don't have HIPAA. And we don't have a lot of the regulations around privacy. We still need to make sure that we're taking those concerns into account when we're serving our populations. But it creates enormous freedom to create solutions that actually serve providers and patients, instead of the ones that exist in developed markets, which are often really set up for billing purposes.
You looked like you wanted to jump in, Aparna. Maybe
I
you were just
completely
nodding
agree.
vigorously. Okay.
No, because there are solutions around the global south. We work intimately with the field. The populations are there. The problems are there, and the solutions need to come from there,
Right.
and not top down.
So
Yeah. Somebody brought up earlier today, I think they were talking about looking at emerging markets for developing innovation. I think that's an enormously powerful thing. I mean, to develop certain technologies and innovations, I mean, Raj has been enormously successful in implementing, let's say, US-based type of approach into an emerging market. I think that's novel in a sense. The US, if you use US healthcare-based system innovation, it's there to decrease cost.
Yeah.
Well, hopefully maintaining quality, but its main goal is to decrease cost in a very broken healthcare system. And the emerging technology is really where most of the mobile health and digital technology is being developed and tested. So it's a great opportunity to look at that and to take advantage of that.
Great.
And I would also just add that the solutions that I think we're trying to provide to these populations, even just basic medical services, is something that everyone should have access to. I agree. This is not the highest levels of technology in terms of the actual treatments, right?
Yeah.
This is low-hanging fruit. This
Yeah,
is
absolutely.
starting someone on an aspirin or metformin or getting them the proper blood pressure checks and the medications. This is stuff we know it works. It's just a matter of how do you disseminate that using technology to the people who don't have access. And I think that's a common theme I see in terms of
Great.
on the stage.
I want to very quickly get a quick question from the audience. And I know that we have Rebecca Disler here, who's the Director of Global Health Initiatives at Element, and is someone who spends a lot of time thinking about scaling innovation in global health. So Rebecca, please.
Thank you. Thanks, Michael. And thank you to the panelists for this conversation. Some quick context for this very specific question. Element develops an AI-based solution for biometric identification. It uses the existing cameras on mobile devices, so no specialized hardware, works offline without connectivity. And over the last few years, we've been working with health research institutions across Cambodia, Bangladesh, and Mozambique to extend the solution to infants and children to create a digital identity to link them to digital vaccines and health services. Something we heard along our journey from organizations and institutions was this technology is exciting, it's solving a challenge that we haven't been able to solve yet, but come to us when it's ready. Come to us when you have generated evidence that this will impact health outcomes. And so I want to take the panelists back to kind of the start of your own scaling journeys, because generating evidence is something that's really important in that scaling journey, but it's an expensive endeavor. It can be complicated, particularly for other technology companies in the room that may not come from the public health background. My sort of specific question is, how do you incorporate evidence-generating activities into a business plan? And really, I think having both the private sector and the nonprofit models on stage, how does that change if you're talking to an investor versus a donor? Thank you.
Great question.
Yeah.
Feel free. Yeah.
So, I mean, it's important that you only scale up a proved solution. You don't have that much money to waste on a solution that has not been proved. So we start off as research studies. Every program of ARMMAN has been proved. We did an RCT. Amritsar had a RCT supported by DFID UK, which proved impact, and then we scaled it up. Extremely important. And I think if you kind of put it across donors correctly, about the fact, and I think donors also want to see impact data, right? They want to know that the money they spent has led to value. And that's only possible when you kind of generate evidence and only scale up after that, right? So imagine scaling up a solution that doesn't have impact. I mean, that would be horrendous. Yeah.
I would echo that. I think, I'm sure you would, if you can publish the results
Yes.
that you're doing, work with medical societies. We're very fortunate to develop an early partnership with the American College of Cardiology, and through that partnership, we've analyzed 170 million unique adult lives in the US, so 1 out of every 2 adults. We probably have EHR de-identified analysis records of those patients over the last 10 years. And so we were able to show some high-level population results to some of these government health systems to say, yes, our platform is robust enough to handle Indonesia, which has 200+ million people, or Malaysia, or India. And so these are things that we had to prove and create evidence and actually publish that evidence, which we're doing actively. So,
Sylvana, your whole enterprise is building trust. So
Right. Yeah,
evidence
it's a
is big
really,
piece.
really important question. So thank you for it. I think one of the things we really struggle with in markets like the United States, when value-based care models have started developing, models like Iora Health and Oak Street Health, for example, that have been really successful in the United States, they're able to prove the impact of their work because we have a third-party payer system in this country, and that third-party payer has historical data on patient populations. In Bangladesh, 1% of Bangladeshis has insurance, and it's all inpatient care. So there's no payer who has data. So we've introduced an innovative financing model whereby you pay a flat rate for unlimited access to services. For a price point starting at $30 a year, going all the way to $350 a year, you can come see a doctor every single day. Now, how do we measure that having that ongoing access to outpatient care is actually impactful? It's very difficult because there is no baseline data that exists. And it's hard for me to go to investors and say, please fund this research for me. So we're actually setting up a nonprofit. to help to deepen the research that we are able to do. What we have been able to do in our own piecemeal way is we have people who've signed up for the membership plans, and we have people who've come in off the street to access a la carte services, and we do have initial data within those populations based on self-reporting that people who access the membership plans are less likely to be hospitalized. But it's not at the robust level that you might hope it be. So it is a real challenge for us.
Very final words.
Well, I mean, it is an enormously important question. But think about it, if you're a young startup and you basically are trying to survive day to day, week to week, how do you actually make a commitment to do that type of evidence-based research? I think one is you just have to do it. You have to look at your investors, and they're not going to want to fund that. They're just not going to want to fund that. And you have to say that's part of the obligation that we have to do, looking at the impact data. But there's one unsung thing that I think may not be obvious. Getting the correct data to do your impact is not available in many cases. A very simple example is we want to look at our financial impact and implementation of our technology. And we look at the current cost of a program that's looking to scale what we're doing, and we're trying to get baseline financial costs, let's say, for teaching and training and the implementation of this, let's say the frontline healthcare workers for delivering this type of service. Some places will provide it, some people have it, and some people don't. How do you actually get that impact data? You know, getting data and getting the appropriate one is one of the things that we work on quite extensively, but it has to be a commitment. And I think on the other end, I think the donor should probably have a certain level of expectation for the quality of studies that you do. That also is really important. I can, unfortunately, as a research scientist reading this stuff for 35 years, there's a wide variety of quality out there, and it's really important to look at that appropriately.
Great. Unfortunately, that's all the time we have, but please join me in thanking our panelists. I hope you're both inspired and got a little bit of a reality check here, but thank you all so much.